Hi guys, can everybody hear me? Right, so I think we'll get started. So my name's Dory. I'm an FY2 doctor in the northeast of England. I've got an interest in neurology and neuropsychiatry, and I've got a talk today looking at headaches. So headache is one of the most common neurological complaints you'll encounter, both in exams and in clinical practice, and it appears really frequently in UKMLA style questions because it tests judgment rather than recall. So this is things like recognizing patterns, identifying red flags, and deciding when investigation is necessary and when it isn't. I think I've got access to the chat, so if anybody has any questions, just shoot them into here and I'll answer them when I can. So today we'll cover the diagnosis and management of key primary and secondary headache disorders. So those include tension type headaches, migraine, cluster headache, IIH, trigeminal neuralgia, and temporal arteritis. So I chose those last three conditions deliberately because they don't really fall into any other sort of boundaries within the curriculum, and other things like subarachnoid hemorrhage will be covered in future sessions. So I think it's important that we distinguish between primary versus secondary headache. So primary headaches are disorders in their own right without an underlying structural or systemic cause. So for example, things like tension type headache, migraine, and cluster headache. Whereas secondary headaches are symptoms of another pathology, which might be vascular, inflammatory, infective, neoplastic, or traumatic. And it's important to be able to distinguish between these two in exam questions. And again, importantly, severity alone doesn't distinguish primary from secondary headache, because primary headaches can be severe and disabling, as we'll discuss later. And what matters is those red flag symptoms that I'll go through in the second half of this talk. So we'll start off with the primary headaches, which account for the overwhelming majority of headache presentations. Generally, these are recurrent, stereotyped, associated with completely normal neurological exam. And in exam questions, when you're explicitly told that the neurological exam is normal, that information is rarely incidental. And it's usually signaling that the headache is primary and that reassurance and appropriate first-line management are the safest next steps. So the first type of headache we'll talk about are tension type headaches, which I'm sure a lot of us will have experienced. So tension type headaches are the most common primary headache disorder with a lifetime prevalence of around 40%. So 4 in 10 people will experience a tension type headache during their lifetime. It can occur at any age and affects men and women relatively equally. So the exact pathophysiology of tension type headache is not fully understood. So current sort of theories or models suggest a combination of peripheral mechanisms, so things like sustained contraction or tenderness of pericranial muscles, and other sort of central mechanisms. And this helps sort of explain the classic presentation, which is a tight band around the head or a vice-like sensation clamping down on the head. So the pain is pressing or tightening rather than throbbing, reflecting sort of sustained pain input rather than pulsatile vascular pain, as is the case with migraine. Things like psychological stress, poor posture, sleep disturbance, and MSK tension are commonly associated with tension type headache. So patients, like I said earlier, patients typically describe a bilateral headache with a pressing or tightening quality. The pain is non-pulsatile and is usually mild to moderate in severity. It's not worsened by physical activity, and crucially, there's no vomiting, photophobia, so light sensitivity, or phonophobia, sound sensitivity. You can get mild nausea in some tension type headaches, but once sensory sensitivity or vomiting becomes prominent, then migraine becomes more likely as a diagnosis. The duration of these headaches can range from 30 minutes to several days, and oftentimes the neurological examination is entirely normal, or it will be in exam questions. There are no investigations required if the history is typical and the neurological exam is normal, and neuroimaging is never indicated for isolated tension type headache. In terms of management, this is largely conservative, so reassurance and education are often the most effective interventions. Acute treatment consists of simple analgesias such as paracetamol or NSAIDs, and preventative treatment is rarely required, though in chronic or disabling cases, low-dose amitriptyline may be used. And the way amitriptyline works is by enhancing descending inhibitory pathways, reducing central pain sensitization rather than treating the acute pain of the headache. Opioids, particularly codeine, should be avoided because they're inefficacious and there's a risk of medication overuse headache. I think a key clinical point here is that many patients labeled as having severe tension type headache are actually experiencing misdiagnosed migraine. And oftentimes in questions, the patients won't, the severity of the headache won't be disabling to the patient. And at the top here, I've got some exam buzzwords. So if you see things like tight band, bilateral, or non-pulsatile, that's often suggesting a tension type headache. So I'll be monitoring the chat. So if you have any questions, just let me know. Otherwise, I think we'll move on to migraine. So migraine's also very common, but this time it's got a very strong female predominance. It often presents in early adulthood, but can occur at any age. So in terms of etiology and risk factors, migraine is a neurovascular disorder, which involves sort of abnormal sensory processing and has a strong genetic predisposition. And it's involved with the sort of trigeminal nerve and the vasculature surrounding it, leading to altered modulation of pain and sensory input. And so this is why migraine is not simply a headache, but a syndrome involving nausea, light sensitivity, sound sensitivity, and you might also get aura, which you don't get with tension type headache. Common triggers include things like stress, sleep disturbance, and travel, hormonal changes, missed meal, and then the dietary sort of components. Most typically are cheese, chocolate, and caffeine. And there's the chocolate mnemonic that can be used to remember all these things. In terms of presentation, migraine presents as a recurrent episodic headache lasting between 4 and 72 hours. The headache's often unilateral, but can be bilateral sometimes, although that's not very typical for exam questions. The headache's usually throbbing or pulsatile, and severe is moderate to severe and often disabling. Associated features include things like nausea, vomiting, photophobia, and phonophobia, which are more diagnostically useful than pain location. Around 1/3 of patients experience aura, which is a fully reversible visual, sensory, and speech symptom that might develop gradually over minutes and resolves within an hour. The gradual evolution is a key feature distinguishing migraine aura from TIA, which is, in the case of the latter, sudden and maximal onset. So I want to stress the point that oftentimes migraine is disabling. And what I mean by this is often you'll talk to a patient with migraine and they might suggest that as soon as they get the migraine, they have to go to their bedroom, sit in a dark room and sleep it off. Whereas somebody with tension type headache can typically go about their day. Again, no investigations are required if the history is typical and the neurological exam is normal. And again, neuroimaging is not indicated for isolated migraine-like headache. So management, again, reassurance and patient education is key. And acute treatment involves combination therapy, so paracetamol or an NSAID together with an oral triptan. And these triptans reduce trigeminal pain transmission and they modulate cranial vascular tone, hence why they can be contraindicated in people with ischemic heart disease. And preventative treatments should be considered if patients experience 4 or more migraine attacks per migraine days per month, or if attacks are significantly disabling. So you might use things like propranolol, and you should be cautious of asthmatics. Topiramate, again, cautious with women of childbearing age, and amitriptyline, which is sedating, so you might be a bit more cautious with older patients. Again, education around medication overuse is essential, and we'll get on to medication overuse headaches later. So similarly to the last slide, the top bit of this slide shows the exam buzzwords. So things like throbbing and pulsatile for character. It's very often unilateral, and patients often want to go and sit in a dark room. So the third type of primary headache we'll go through is cluster headache, which is rare and shows a strong male predominance. It most commonly affects young to middle-aged adults and is strongly associated with smoking. And cluster headache is part of a group of headache disorders called TACs, or trigeminal autonomic cephalalgias, and that includes things like paroxysmal hemicrania, hemicrania continuum, and so on. But cluster headaches are the only ones that are really relevant for the exam. So cluster headache arises again from dysfunction of the trigeminal autonomic reflex, and this explains sort of the circadian pattern of attacks and associated autonomic features. It's associated and triggered by smoking, and alcohol can trigger attacks during active bouts. It can also be triggered by strong smells and sleep disruption. In terms of presentation, cluster headache presents with excruciating, severe unilateral pain, typically orbital or supraorbital or temporal. Attacks last between 15 minutes and 3 hours and can occur up to 8 times per day, often at predictable times, hence the circadian rhythm to them. A defining feature is marked restlessness or agitation during attacks. So patients in the questions might pace or rock rather than lying still, which is in contrast to migraine patients who do want to lie still and go into a dark room. There will also be, and there has to be, ipsilateral cranial autonomic features, and these include things like lacrimation, conjunctival injection, nasal congestion or rhinorrhea, as well as eyelid edema and ptosis. So in terms of investigation, cluster headache is a clinical diagnosis again, but most patients undergo MRI with contrast to exclude secondary causes mimicking attacks or sort of other types of headache. Management. So acute management consists of high flow 100% oxygen via non-rebreather mask and subcutaneous or intranasal triptans. Oral treatments are ineffective due to slow onset, whereas the subcutaneous treatments and intranasal treatments are a lot quicker. Preventative therapy is initiated in specialist care only, and most commonly with verapamil. Again, verapamil reduces attack frequency, but you have to be certain that you have to do ECG monitoring because there's a risk of heart block. A useful example is that unilateral headache that responds dramatically to indomethacin is more likely to represent paroxysmal hemicrania rather than cluster headache. And you might sometimes be asked about this because it's quite a bundle presentation. Again, exam buzzwords. So you might think of autonomic symptoms like conjunctival injection, rhinorrhea, and pacing or banging their head. So this is quite key in terms of how these patients present, is that they will be markedly distressed and they will pace around the room. And it's a massive contrast to how migraine patients present. The last slide isn't technically a primary headache. It is medication overuse headaches. So medication overuse headache affects patients with pre-existing migraine or tension type, and is a common presentation in chronic headache clinics. It results from frequent exposure to acute headache medications, leading to central sensitization and altered pain modulation. And over time, the brain becomes more headache prone between doses. Common offenders include things like triptans, opioids, and other sort of analgesics being used for more than 10 days per month. And then simple analgesics like paracetamol and non-steroidals like ibuprofen being used for more than 15 days a month. The presentation, in terms of presentation, the headache typically mirrors the original headache phenotype, and occurs on 15 or more days per month. And patients often describe temporary relief with analgesia followed by rebound worsening. Again, the diagnosis is clinical and it involves things like a headache diary and a medication use diary. And management centers on education and stopping the overuse medication without tapering. And withdrawal headaches are expected for days to weeks with gradual improvement over time, and sometimes might take up to 12 weeks. So that finishes the first part of the talk on primary headache. This is a table that I've repurposed from the British Association for the Study of Headache guidelines, so the BASH guidelines. I think it's a good table because it sort of goes through different parameters of each headache type and compares them side by side. And this is really all you need for exam purposes. I'll leave this on screen for a few seconds if anybody wants to take a photo of it. Right, so I think we'll start off with the first question. So I'll read out the question and I'll give you some time to answer it. So a 33-year-old woman presents with headaches occurring 2 to 3 times per month. The pain is described as bilateral and dull, lasting around 12 hours. She reports mild nausea, but denies vomiting, photophobia, or phonophobia. Her mother suffered similar headaches throughout her adulthood, and neurological examination is normal. So the answer is migraine without aura. So tension type typically doesn't have nausea, especially in exam questions, and it doesn't really tend to be a family history. Medication overuse headache, there's no evidence of medication overuse here. Cluster headaches are often, cluster headaches are always rather unilateral, and always have autonomic symptoms accompanying them. And there's no red flag symptoms here to suggest secondary headache, hence the answer of migraine with aura, without aura rather. So question 2, a 58-year-old man experiences visual disturbance described as a shimmering blind spot that gradually expands over 15 minutes, followed by unilateral headache with nausea and photophobia. Symptoms fully resolve within 4 hours and neurological exam is normal. What feature of this history most strongly supports migraine aura rather than TIA? So the correct answer is the gradual progression of his symptoms. So if we go through them one by one, so age doesn't exclude migraine because although it has predisposition for early adulthood, it can occur at any age. Visual aura is well documented, and oftentimes patient will get visual aura prior to having their headache. Headache can follow TIA, and both can resolve within 4 hours. So TIA is maximal at onset, whereas the aura in migraine is gradual and will progress and end within the hour. Right, next question. A 39-year-old man presents with severe unilateral temporal pain lasting approximately 90 minutes. Attacks occur nightly for the past 10 days. He reports nausea and photophobia during attacks. Examination between attacks is normal. Which additional feature would most strongly support diagnosis of cluster headache? So the correct answer is the ipsilateral lacrimation during pain, which is the characteristic autonomic symptom that you get with cluster headache. Throbbing pain is more migraine type, whereas the character of cluster is stabbing pain, a sharp stabbing pain. Cluster is never or is not really relieved by simple analgesia like non-steroidals. Patients with cluster headache pace dramatically and don't prefer to lie still during attacks, unlike migraine patients. And cluster headache typically is complete within 3 hours. Okay, so we'll go on to secondary headaches now, and I'll cover IIH, trigeminal neuralgia, and giant cell arteritis. So secondary headaches arise from underlying pathology and must be considered when a headache does not fit a classic primary pattern. The approach sort of involves recognizing red flags, performing a focused neurological examination, and selecting appropriate investigations. And this is often what exam questions will test you on when testing secondary headache. So a good acronym or mnemonic to know is SNOOP5. And this is an acronym that sort of summarizes key headache red flags. So systemic symptoms like fever, neoplasm, so cancer, any neurological deficit, sudden onset of headache, which might suggest subarachnoid hemorrhage. New headache over 50 raises concern for things like giant cell arteritis or cancer or so on. Papilledema indicates raised intracranial pressure and alters the sort of investigation sequence. And pregnancy raises concern for things like CVST or eclampsia. And pattern change, again, should always sort of light up as a red flag and prompt reassessment. So the first thing we will talk about is idiopathic intracranial hypertension, or IIH, which predominantly affects young women and has a strong association with obesity and typically recent weight gain. So the condition is characterized by raised intracranial pressure without an identifiable structural cause. So risk factors include things like obesity, recent weight gain, including pregnancy, female sex, drugs including the combined oral contraceptive pills, steroids, retinoids, or other vitamin A analogs, lithium, and it's not associated with intracranial mass lesions, and there's no structural cause. So patients will typically present with a daily or near daily headache, often worse in the morning, and exacerbated by coughing or straining or Valsalva sort of maneuvers. Visual symptoms are also common, and these include things like transient visual obscuration. And fundoscopy will show papilledema with an otherwise normal neurological exam. So to investigate IIH, you must do an MRI brain with venography, and this is because you need to exclude cerebral venous sinus thrombosis. Lumbar puncture also confirms the diagnosis by demonstrating an elevated opening pressure, which is typically greater than 25 centimeters of water. And again, fundoscopy will show papilledema, which you can see in the image on the lower right-hand corner. So management, so first line is weight loss, and it's exceedingly common that GLP-1 analogs like semaglutide are used to achieve this. And acetazolamide can be used temporarily, which reduces CSF production because it's a carbonic anhydrase inhibitor. And if the patient has any visual changes, then they should get an urgent ophthalmology review, and as well as a neurology referral. Surgical options are reserved for refractory or vision-threatening disease. So in the exam, if you see young, obese, blurred vision with normal imaging, then that's typically IIH. So the next secondary type of headache we're going to talk about is trigeminal neuralgia. This typically affects older adults with a slight female predominance. Younger patients raise concern for secondary causes, such as multiple sclerosis, where it occurs in that population. So the most common cause is neurovascular compression of the trigeminal nerve root, and it's often idiopathic. This leads to focal demyelination and ectopic firing, causing the symptoms. Secondary causes of, or non-idiopathic causes of trigeminal neuralgia include things like multiple sclerosis and tumors, and some red flags to look out for include sensory changes, hearing loss, optic neuritis, and a head and neck cancer risk. In terms of presentation, patients experience sudden severe electric shock like facial pain lasting seconds to minutes. The pain occurs in paroxysms, so episodes, is unilateral and is triggered by light touch, chewing, talking or brushing teeth, and between attacks, patients are pain-free. In terms of investigation, again, MRI of the brain is recommended to exclude secondary causes, particularly in younger patients or those with atypical features. Their diagnosis remains primarily clinical. And in terms of management, the first-line treatment is carbamazepine, and this works by blocking voltage-gated sodium channels. Surgical options, and you might also use alternative anti-seizure medications or anticonvulsants if carbamazepine is not tolerated. And surgical options such as microvascular decompression are considered only when medical therapy fails. And again, the neurology referral should be made if there is poor response to treatment or suspected secondary cause or atypical features of the trigeminal neuralgia presentation. And the image on the right-hand side shows the different branches of the trigeminal nerve. So you've got the ophthalmic, maxillary, and mandibular divisions, and typically it'll affect the ophthalmic or the maxillary branches of the trigeminal nerve. So the last topic we're going to talk about is giant cell arteritis, and this occurs almost exclusively in patients over 50 and is more common in women. It's strongly associated with polymyalgia rheumatica, so you might also see some some symptoms relating to the polymyalgia in the same question. So it's an immune-mediated granulomatous large and medium vessel vasculitis. Risk factors include older age, female sex, and Northern European ancestry. And again, it's frequently associated with polymyalgia rheumatica in around 50%, probably more, for exam purposes. So in terms of presentation, patients present with new onset headache, scalp tenderness, jaw claudication, and systemic symptoms like fever, fatigue, weight loss, and visual symptoms when they occur are a medical emergency. You might also note that the temporal artery might be tender, thickened, or might have reduced pulsation. So in terms of investigation, at the bedside, you can take an ESR and a CRP, which are inflammatory markers and are typically raised, though ESR can sometimes be normal. And temporal artery biopsy is diagnostic, but might show a false negative because of skip lesions. And where temporal artery biopsy might be delayed, you can do ultrasound, which shows the halo sign because of the inflamed blood vessel. So in terms of management, immediate high-dose corticosteroids are required, and they always need a taper because of how long you use them for and the doses that you use them, at. So oral methylprednisolone is first line, and you can use higher doses with visual symptoms, and IV methylprednisolone is required if you have visual loss. Wherever there is GCA, there is rheumatology involvement, and ophthalmology should be involved if visual symptoms present. And again, these two diagrams in the bottom right-hand corner show where the temporal artery is and where the patient might feel tender. And characteristically in polymyalgia rheumatica, you get sort of shoulder girdle and hip pain, and that's what's depicted in the images on the left-hand side of the right-hand corner. So we'll go on to do the last few questions. So a 27-year-old woman presents with daily headache for 3 months. The headaches are worse on waking and when coughing. She reports transient visual blurring lasting a few seconds when standing up. Examination reveals bilateral papilledema. Neurological examination is otherwise normal, and MRI brain is normal. What is the single most appropriate next step? So the answer is CT venography, which can be a replacement for MR venography, where MR is difficult to achieve. So you wouldn't start acetazolamide because you'd have to wait diagnosis before treating it. You would not do a lumbar puncture immediately, so you have to do imaging before any lumbar puncture to exclude any sort of space-occupying lesions or CVST, because that can lead to herniation of the posterior brain through the foramen magnum. Urgent neurosurgical referral, there's no mass lesion on the MRI, and there's no structural lesions in IIH, so there wouldn't be a real role for neurosurgery unless the IIH was refractory to treatment or there was severe visual loss. And high-dose corticosteroids are not indicated in IIH. So question 2, a 74-year-old woman presents with a 2-week history of headache. She denies jaw claudication and visual symptoms. Examination shows mild scalp tenderness. ESR is 18 millimeters per hour, which is normal range for her age, and CRP is pending. What is the strongest indication to start immediate high-dose corticosteroids? So the answer is new onset headache in a patient over 50, and I recognize this question might be a little bit pedantic, but I think it's just sort of laboring the point that usually in older adults, where there's an exam question and they've got a new headache, you have to think giant cell arteritis. So elevated ESR, as I mentioned earlier, ESR can be normal in GCA, and here the ESR is normal anyways. Scalp tenderness is supportive of GCA, and absence of visual symptoms does not reduce urgency, so you'd still give the steroids as soon as you diagnose. And biopsy may confirm diagnosis, but management should not be delayed. So we'll move on to the final question. A 29-year-old woman with severe right-sided facial pain, or rather a 29-year-old woman presents with severe right-sided facial pain. The pain is described as electric shock-like, lasts seconds, and occurs in brief paroxysms. It is triggered by talking and brushing her teeth. Between attacks, she is pain-free, and neurological examination is normal. Which feature in this history would be most concerning for a secondary cause of trigeminal neuralgia and therefore mandate further investigation? So the correct answer is onset before the age of 40. So in terms of pain triggered by light touch, this is typical for trigeminal neuralgia. Pain that's confined to the maxillary division. So the trigeminal neuralgia can affect any branch of the trigeminal nerve, including the ophthalmic, maxillary, or mandibular divisions. Onset before the age of 40 is correct because it might suggest a secondary cause, including MS and tumors that cause compression or demyelination of the trigeminal. Brief duration of pain. Again, the pain lasts seconds in trigeminal neuralgia, and there are often pain-free intervals, so it's not constant pain. So that concludes the talk on headache today. It was a bit shorter than I anticipated, but I'm happy to stay for any questions if anybody has them. I think I'll see them in the chat, and I can respond on here. Or if you don't want to ask a question in the chat, you can always email me, and my email's on the screen now. And I've just put up the QR code on the upper corner. I don't know if you can see it on YouTube, but if you could leave some feedback, that'd be really useful. Otherwise, the link is www.mindthebleep.com/webinars. Okay, so I think if nobody has any questions, I'll probably end the session now. But thank you for coming, and sorry about the half an hour postponement. But yeah, I hope you guys enjoyed that. There'll be future sessions run by my colleague and by me, but those will be advertised in due course.